Now, the headings that will be broadly covered are National Cancer Registry Program, the gynecological cancer incidence estimates, the reasons for the increasing cancer burden in our country, and what are the various cancer control activities that are in place today. Now, what is the importance of cancer estimates? We all know that the incidence rate is a very good indicator of burden of cancer. And therefore, it helps us to monitor and evaluate the success of the existing cancer prevention and control programs. And it also helps us to formulate appropriate cancer control measures. So who does this job? This job of collection of data. It's done by the National Cancer Registry Program, or the NCRP. Now, you can consider NCRP as a kind of storehouse of data surveillance on cancer in our country. And it collects the data through two sources. One is the population-based cancer registries, that is PBCRs, and the other is hospital-based cancer registries. Now, population-based cancer registries basically give us the estimates of a geographically defined population. And the hospital-based cancer registries, they tell us the presenting complaints, the diagnosis, and the treatment of cancer. This NCRP is actually housed at ICMR in Bengaluru. And so how is this data collected? We all know that cancer is not a notifiable disease. So we need to have an extremely robust and active registration process. So this is done by some trained person. They actually visit hospital to hospital. They go from pathology to pathology labs, and then they collect the data. This data is then assimilated, and then finally it's published. So from the time of collection of data to the time of publication, there's usually a time lag of 4 years. So we also need to have the future estimates as well. So what are the primary objectives of NCRP? First is to generate reliable data on the magnitude and patterns of cancer in India, both at the national level as well as at the state level, and also to provide us with future estimates. Now, there is another body called the Global Cancer Observatory, which actually gives us the global estimates as well as country-specific estimates. So the GloboCan 2020 says that there are at present 19.3 million incident cancer cases worldwide for the year 2020. And India at present ranks third only after China and the USA. And it has also predicted a rise of about 57.5% 20 years from now for our country. So the main gynecological cancers that I shall be covering: cervix, ovary, and corpus uteri, with more stress on cervical cancer. As you can see from this, that cervical cancer bears the major burden, that is 10.6% of the total, followed by ovarian cancer, which is 6.2%, and lastly, endometrial cancer or corpus uteri cancer, that is 3.7%. Now, this is a bar graph giving us an estimated proportion of the various cancers according to their anatomical locations. And you can see from this, the blue one represents the female ones. So the cervical cancer is actually second in number, just following breast cancer. And if you look at the total, that is total of the gynecological cancers, together they form 20.5% of the total cancer load. That is almost 1/5 of the total cancer burden. Now, the age-wise distribution: in the age group of 15 to 39 years, ovarian cancer and cervical cancer almost share the burden at 7.3 and 7.1% respectively. Whereas after the age of 40 years, you can see that cervical cancer shoots up. That is almost 12.3%. Now, these are the risk factors. We all know cancer is a multifactorial disease, and these are some of the common risk factors which are seen across all cancers. So an aging population, sedentary lifestyle, use of tobacco, unhealthy diet, and air pollution are some of the risk factors. So to prevent, we need to take care of the risk factors. So adopt a healthy lifestyle, then limit the impact of carcinogens, vaccinate yourself against HPV, and be aware of your family history of cancer. Now, coming to the first one today, that is cervical cancer. Cervical cancer is preventable. This is the first and foremost thing that we should remember, that it's preventable and also curable if detected early and managed effectively. But surprisingly, we have not been able to prevent cervical cancer in our country, probably because of limited access to public health services and also because of poor implementation of screening tests and treatment strategies. Now, according to NCRP 2020, India accounts for 1/4 of the worldwide burden of cervical cancer. Till a few years back, it was 1/5, and today it is 1/4. So we can see how the situation is. It's quite serious. And it accounts for 6 to 26% of all cancers in women. Now, 6 to 26%, that's a wide range. That's because the values are from different registries of the country. That's why it's 6 to 26. And in India, there's a place in Western Arunachal Pradesh called Papumpare, which has the highest incidence rate of cervical cancer, not just in our country, but in Asia, and it's 27.7 per 100,000. On the contrary, Dibrugarh in Assam has the lowest incidence, that is 4.8 per 100,000. What is the lifetime risk of Indian women? It is 1 in 53, and 17% of all the deaths that occur between the age of 30 and 69 is because of cervical cancer. Also, it is predicted that there will be a rise in 12.8% in the year 2025 as compared to 2020. So what are the risk factors of cervical cancer? First is early age at first intercourse. Second, multiple sexual partners. And third, poor sexual hygiene. Now, what is common in these three risk factors? The factors: an exposure, prolonged exposure, continuous exposure to human papillomavirus. The fourth reason, that is long-term use of OCPs. Long-term meaning more than 5 years of use of OCPs. How does that increase the risk? Now, OCPs have an estrogen component. This estrogen component, if given continuously, then it brings about certain changes in the epithelial layer of the transformation zone, which harbor HPV, and makes it difficult for the person to eliminate this virus after a certain time. So there is continuous exposure to HPV, which eventually leads to cervical cancer. So you can say that in all the four risk factors, the common factor is actually HPV. So HPV is a group of 200 related viruses and is a well-established cause of cervical cancer. Almost all sexually active, in fact, 100% sexually active people, they are infected with HPV. But 90 to 99% of the women are able to eliminate this virus from their body because of their own immune system. And it's only 1% high-risk HPV that persists and eventually leads to cervical cancer. Now, the sexually transmitted type can be of two types, that is the low risk and the high risk. The low risk is type 6 and type 11. Now, they cause genital warts. It's benign, but nevertheless, it is quite distressing for the patient. And the high risk, mainly 16 and 18, which is responsible for 70% of cervical cancer worldwide. But in India, they are more common. They are responsible for 80 to 85% of the cervical cancers. So how to prevent? Now, primary prevention includes vaccination against HPV, and secondary prevention includes regular cervical cytology examination. So coming to cervical cytology examination, it's part of the screening program. So a few words about VI and VILI first. VI is visual inspection with acetic acid, and VILI is visual inspection with glucose iodine. Now remember, VI and VILI are not cytological tests. They are simply visual inspection tests. So obviously their sensitivity and specificity is quite low. The second one, that is conventional paths that we use more commonly, and liquid-based cytology are cytological tests. The liquid-based cytology also involves study of HPV, so it's called a co-test. So VI and VILI, as I said, are non-cytological tests, so they have a low specificity, but it's more practical for our country. Why? Because it's economical and affordable. You just need a private chamber, an examination couch, acetic acid, glucose iodine, a trained person who can perform the tests, and a few basic gynecological instruments, and that's it. You can perform the test. So it's preferred in low resource settings, and the results are immediate. You don't have to wait for the patient to come back with the reports. So again, it's more practical for our country where majority of the patients are lost to follow up. So it's kind of see and treat. Now, coming to the cytological test, the first one that I shall be talking about is pap smear, the conventional pap smear, where we use a wooden spatula called the iron spatula. This wooden spatula has a bifid end at one end, and the longer limb, you place it on the external os, and then you rotate it by 360 degrees. And it helps to collect the cells from the transformation zone. After that, you prepare a smear. Now, the problem with this is that it does not collect any endocervical cells. So you need to use a cytobrush separately to collect the endocervical cells. So pap smear is cheap. It's a commonly used method, but it has its own limitations. First is sampling issue. Now, majority of these cells are wasted. Why? Because adequate number of cells are not transferred from the cervix to the spatula. And then again, adequate number of cells are not transferred from the spatula to the slide. And secondly, there can be interpretive issues. Why? because when you're using the wooden spatula, there is a high risk of bleeding from the side of the cervix. So that blood contaminates the sample and makes it difficult for us to interpret the results. So to overcome those limitations, we have the liquid-based cytology where we use a cervix broom. Now, as you can see in this picture on the left, the cervix broom, it has bristles of different length. The central ones are longer, which is placed on the external os and it enters the external os. So those longer bristles are the ones which will be collecting the endocervical cells. The ones in the periphery will be collecting cells from the transformation zone. So you kind of place it on the cervix and then you apply a gentle pressure. So once you apply a gentle pressure, then the bristles on the side, they are splayed out, they open out and they cover the transformation zone. After that, you rotate it 5 times in a clockwise direction. Make sure it's 5 times in the clockwise direction and not in the anti-clockwise direction. The reason being, the bristles are D-shaped. The transverse section is D-shaped. As a result, they will collect the sample only if you rotate it in the clockwise direction. Then after that, you place it in the solution, you shake it a little so that you dislodge the cells. Or if you're using Sure Patch, then you can simply snip off the broom from the stick and then drop it in the jar. So the advantages of LBC is that it helps you to prepare a thin monolayered smear with a clear background. Second, there's a reduced rate of unsatisfactory smears because of non-interference by blood, mucus, and also there is no air driving artifacts. And there is increased number of satisfactory smears because you are getting endocervical cells as well. And the most important, you can perform molecular studies for detection of high-risk HPV. And the cellular material can be preserved for future studies as well if required. So this is how the slides look like in case of PAPS and LBC. The left one is PAP. The right, to your right is LBC. So the PAPS, you can see that it has a hemorrhagic background. The cells are all clumped together, lying one above the other. So it's very difficult for you to see the individual cells. But on the left, you can see that the cells, they are all lying in one layer. The background is absolutely clean and beautiful and clear. And the cells, each and every cell can be clearly seen. So what is the WHO strategy for cervical cancer prevention? So it recommends screen and treat or screen, triage and treat for the general population of women. Screen and treat means you perform a screening test and then you treat the condition. Screen, triage and treat means you perform the screening test, then you do a triage test if your screening test is positive, then you treat. What we are doing in India right now is screen, triage and treat. And they say that, WHO says that HPV DNA should be the primary screening test and you start at age 30 onwards and you screen every 5 to 10 years. If the patient is HIV positive, then obviously you will be doing it much earlier. So you will start at age 25 and then you will screen every 3 to 5 years. So what before 30 years? Before 30 years, that is from 20 to 25, it is said that you do pap smears, and from 25 to 29, you can do HPV DNA, but then again, PAPS is preferable. So less than 30 PAPS, after 30 HPV DNA. Now coming to the primary prevention, that is vaccination. So these are the following vaccines that we have. Cervarix, which is a bivalent vaccine against 16 and 18, at present has been discontinued and has been taken off the market, so no longer available. What we have is Gardasil, which is a quadrivalent vaccine against 6, 11, 16, 18. So besides cervical cancer, it also takes care of genital warts. Gardasil 9 is a non-valent vaccine, which has been recently introduced about in 2021 in October in India. And besides 6, 11, 16, 18, it is also active against 5 more types of HPV. So it kind of gives you an extended protection against cervical cancer, 10% extended protection. Now, there's a new kid in the block, Cervavac, and we should be really proud of it because it's our own indigenous vaccine developed by Serum Institute, Pune. And it has been in the market since January 2023 this year. It's a quadrivalent vaccine. And the recommendations are the same as that of Gardasil. So what are the FOXI and CDC recommendations for age and dose of the vaccines? So they say that 9 to 14 years should be the target group. Now, you can give the vaccine anytime between 9 years of age to 45 years of age, but 9 to 14 should be the target age group. Why? Because it said that the efficacy of the vaccine is the maximum or the highest when the patient is not sexually active. So in this age group, you will give 2 doses, one at 0 and another at 6 months. But then again, the second dose can be given anytime between 5 to 15 months because the window period is quite long. The second one, that is 15 to 26 years age group, you give 3 doses, 0, 2, and 6 months, both for quadrivalent and for non-valent vaccine. Then the third group is the 27 to 45 years, again 3 doses, but these patients should be counseled that the efficacy is reduced with increasing age, and more importantly, they should continue to follow the screening recommendations irrespective of the fact whether they are vaccinated or not. Now, there are some special situations where the vaccination recommendations are a little different. First is if the patient or the girl is HIV positive or immunocompromised, and instead of 2 doses, you give 3 doses. Interrupted doses, then what do? If the patient says that I have missed my second or third dose, then you continue with the remaining dose. You need not restart the whole schedule. Pregnancy, it is not recommended. But if inadvertently the patient takes the vaccine during her pregnancy, then no need to advise her termination. Lactation, it can be given. Boys in the age group of 9 to 26 years now form the secondary target group, and it is recommended. So recently, WHO has published in 2022 December some new recommendations, and it says that between 9 to 14 years, you can even give a single dose. 1 dose or 2 dose schedule, both can be followed. 15 to 20 years, again, single dose or 2 dose can be followed. Older than 20 or 21 years, you can give 2 doses with a 6-month interval. But then remember, this is only for Gardasil. With Cervarix, we still do not have enough experience to suggest the single dose. We will continue with the older recommendation for our own vaccine. Now, what is this 90, 70, 90 target by 2030? Now, WHO has given a goal to every country in the world that bring down your cancer cervix incidence rate to less than 4 per lakh, and you will be able to eliminate cervical cancer. So for this, we require 3 pillars: vaccination, screening, and treatment. Vaccination, the target is 90% of the girls should be fully vaccinated by the age 15. Screening, 70% of women should be screened using high performance test. High performance test means your HPV DNA test by age 35 and again by age 45. That is 2 tests should be done. Treatment, 90% of women with pre-cancer and 90% women with invasive cancer should be treated. Now, the values in the bubbles on the side show you the Indian scenario, and this is quite dismal. Instead of 90, only 0.1% of the girls have been vaccinated by age 15. Only 3.1% of the women are being screened, and only 10% are being treated. So we really need to work hard in this department. So after cervical cancer, a few words about ovarian cancer. Ovarian cancer is the 3rd most common cancer, and it constitutes 3.44% of all cancer cases. Incidence rate is 0.9 to 8.4 per 100,000. And it is the leading cause of death from cancer in Indian women. Why? Because they present late to us. So as you can see from this table, the 5-year survival rate is 94% in stage 1. But unfortunately, only 15% of the patients come to us in this stage. On the contrary, 62% of the patients present in stage 3 and stage 4 when the survival rate is just 28%. So what about screening for ovarian cancer? We have transvaginal sonography, serum tumor markers like CA-125, then pelvic examination, but screening tests are not recommended for the asymptomatic or for the general population. Why? Because it's unnecessary wastage of resources, and we have not been able to bring down the mortality rates using these screening tests. But then yes, if the woman has an inherited risk, then she may undergo screening. For example, if she is BRCA1 mutation positive, then screening should begin by 30 to 35 years. And if BRCA2 mutation positive, then 35 to 40 years. Now coming to endometrial cancer burden, Indian women have a lower incidence as compared to her sisters in the Western world. Why? Because it's considered a disease of the elite, disease of the Western world, because the risk factors are like obesity, then your junk food, but then these risk factors are slowly creeping into our society as well. So probably the incidence is on the rise in India as well. So the proportion of disease varies from 1.9 to 3.3% of all cancers in India. And the incidence rate of corpus luteum was found to be the highest in the state of Delhi, which was 4.4 per 100,000 women. But then again, compare this with the Western world where the incidence is 11.1 per 100,000. So we are quite better off as compared to them. But then let's check. In 2006, there were 10,000 new cases. And in 2016, there were 14,000 new cases. So we can see that it's slowly and slowly increasing. Now, why is this, why we are seeing an increasing trend in the Indian scenario in case of endometrial cancer? Because of two major reasons. First of all, we all know that endometrial CA is a disease of postmenopausal women, and this population is increasing because of extended life expectancy. And secondly, because of obesity. So what about screening for endometrial CA? Again, in endometrial CA also, no screening is recommended for asymptomatic women, but then there are certain situations where you need to investigate further. That is, postmenopausal women with vaginal bleeding. Now, 90% of the endometrial cancers, they present with abnormal bleeding. So any postmenopausal woman who comes to you, even with spotting, you must investigate her. Then women on tamoxifen with bleeding or spotting. Remember, women on tamoxifen who is not symptomatic, you need not perform TVS, you need not perform endometrial biopsy, need not screen her. But yes, if she is coming to you with bleeding or spotting, then you will perform a transvaginal sonography to check the endometrial thickness, and you will do an endometrial biopsy. Then people with a family history of Lynch syndrome, they should be counseled that they are at a higher risk of endometrial CA as compared to the general population. So they should undergo yearly transvaginal sonography and endometrial biopsy. Now, what to do when you find incidental endometrial cells on a pap smear? Now, remember, pap smear is only used as a screening test for cervical cancer, not for endometrial cancer. But when you are checking the slide and you find endometrial cells, then you have to investigate that person. So lastly, to summarize, complete information is the first step to a good registry. As I said, a good registry is the backbone of cancer prevention and control. So make sure that the information provided to the registry is complete. Second, vaccinate against HPV. Follow the screening recommendations. Third, recognize the warning signs. Warning signs like intermenstrual bleeding, postpartum bleeding, postmenstrual bleeding. Don't take them lightly. Visit the doctor immediately. Create awareness about healthy lifestyle, early diagnosis, complete treatment, and of course, a strict follow-up. And lastly, organize mass awareness campaigns to address HPV vaccine-related myths and misconceptions. Thank you so much.